I'm joined by Dr. Funke Afolabi-Brown. She's a board-certified sleep physician and the founder of Restful Sleep MD. She helps high-achieving women and their children prioritize sleep, achieve optimal health, thrive, and live to their fullest potential. She does this through speaking, coaching, workshops, seminars, and other various programs. She's been a guest on over 70 podcasts and has presented at various national and international conferences. She also works with organizations and businesses to improve their health by incorporating healthy sleep as part of their wellness journey. And today we are going to be talking about children's and parents' sleep. So thank you, Dr. Funke, for joining me today.
Thank you so much for having me, Dr. Nishi. I'm looking forward to this conversation.
As am I. And for anyone watching, if you're new to this channel is all about sleep education for physicians and therapists. As physicians, we only get about 2 hours of sleep medicine training during medical school, but all of our patients have to sleep. So subscribe to this channel if you want to learn more about how to support your patients with the power of restorative sleep. I'm Dr. Nishi Bhopal. I'm a physician specializing in integrative psychiatry and sleep medicine. So Dr. Funke, we are doing a Women's Sleep Summit in a few weeks. Could you tell our viewers about that?
Yes, this is so exciting. So we had conversations, maybe a few weeks ago, and we just talked about the fact that women's sleep is often neglected, right? And so as sleep specialists, yourself, myself, as well as 6 other experts are really coming together in presenting this summit, and the goal is really to empower women to prioritize sleep, to help them understand what exactly is going on when they do sleep well, when they don't sleep well, and how to get restful sleep. Because a lot of the information out there may talk about getting 7 to 9 hours of sleep, but sometimes it doesn't seem like a reality for most working women. And so the goal of this one is to provide education as well as to empower them. And so I think it's really going to be very beneficial for women out there.
Fantastic. And I'm really excited about this event. And so it's taking place on March 4th and 5th online. It's free. Everyone is welcome to attend. It's called The Power of Rest, a sleep summit for women. And you can sign up at womensleepsummit.com, and we'll show the link on the screen here and in the video description below. So thanks, Dr. Funke. So we're talking about children's sleep and parent sleep and tips for physicians to support their pediatric patients with sleep, but also the parents of those pediatric patients. So let's start by talking about how children's sleep can impact a parent's sleep.
Yeah, it's one of the things I just noticed very quickly in my practice was that when parents bring their children into the clinic, the only reason why parents are able to realize their kids are not sleeping is because they are not sleeping, right? If you slept through your child, lack of sleep, then you probably wouldn't know. So you wouldn't bring them to care, right? So definitely is a big sleep disruptor, right? When we talk about different things that can impact sleep for parents, we talk about their work obligations, we talk about like any medical disorders they may have or stress and anxiety. But if your child is not sleeping well, no matter what the reason is, you as a parent are not going to sleep well. And that's why the work that I do really is focused on helping both, right? Because they are dyads, right? If your child doesn't sleep well, you don't sleep. And if we fix your child's sleep, then we know that, okay, if you're still having sleep issues as a parent, then that's where we're really going to need to own down. And so it is so interrelated that it is a big issue.
Yeah, and it's really interesting because so I work with adults only, right? And so they'll tell me that their kids, are not sleeping well, or they'll ask me for tips. And I'm not a pediatric sleep specialist. I'm an adult sleep specialist and psychiatrist. And even though in our sleep fellowship, we did have pediatric clinic once a week, I don't feel like I have a great handle on kids' sleep. And so I can imagine for people who haven't done a sleep fellowship, it's maybe even more challenging, right? Especially if you're not a pediatrician. So I'd love to talk a little bit more about, things that doctors can look out for or parents can look out for in their kids. So let's jump into some common sleep disruptors in children.
Absolutely. And what you're saying is so right. Most of the time, even as pediatricians or, people that are not specialized in sleep, many times, unfortunately, what I hear is, just hang in there, your child will outgrow it. And that's a very common sort of recommendation that's given. And you think about all the years, all the stress that that's causing for the family, all the disruptions the child may have in their learning, and all those things. It really is a problem. So now when it comes to figuring out what should I be looking out for if either my child or my patient has sleep issues and is in that pediatric age group, there are different things. There, I sort of group them into, 3 different categories, because I think that makes things really easy. Because when they show up, usually it's like, oh my gosh, there's chaos, the sky is falling, nobody's sleeping, I'm so overwhelmed. And so when we scale it back and say what exactly is going on, that really then helps us to develop an approach or an intervention that is really suited to that child's needs. And so they may come in and say, my child is not sleeping, right? That's the common complaint. So for me, the next question is, why is your child not sleeping? Like, what is going on? Is it difficulties falling asleep? Is it difficulties maintaining sleep, kind of like insomnia, right? Is it a difficulty with them waking up early, right? Or are they fighting sleep? So when we kind of lump that in those categories, then I sort of go into this broad kind of bucket. So the first is, are there medical problems that are going on? So there are medical problems that can disrupt your child's sleep. So things like sleep apnea, which occurs in adults. It's actually not as common in kids, but actually relatively common. Up to 1 to 5% of children have sleep apnea. Is it restless leg syndrome? And that gets really, really tricky, because restless leg syndrome, those discomforts that we experience in our legs, usually in the evening, that leads to the urge to keep moving your legs and can delay sleep onset, can happen in children, especially if you have a child who's maybe a picky eater, or, some children who may have developmental differences like ADHD and things like that can actually have a higher incidence of restless leg syndrome. So the issue with that is it's hard to elicit that history from them. So it does take a whole lot of creativity, almost like an investigator kind of approach to figure that out. But that's a big one too. Is it, things like narcolepsy? We tend to see that more in, adolescent age group, but where they're extremely sleepy despite having relatively good or sufficient sleep at nighttime. Could it be insomnia? So the same way we have insomnia in our adult population, our kids also have insomnia. It may present differently. They may be fighting bedtime. They may be in bed for prolonged hours. They may be going back and forth and saying they need you to come back to bed with them and things like that. And then could it be medical sleep issues that can disrupt sleep? One thing I see frequently as a pulmonologist is asthma. So things like asthma or breathing difficulties, of course, seems to tend to get worse at night. And so that can disrupt sleep, or reflux or things like that. So there are many, many things that can disrupt your sleep from a medical standpoint. The next category, I sort of call them more behavioral, and that tends to be quite common, especially in, our younger kids, and also even in adolescents as well. So with that, you may have them fighting bedtime. So we call it sort of the limit setting, where they are making all kinds of requests. All of a sudden, they need to go to the bathroom for the 10th time, or they need you to verify that there's not a monster under their bed, or, they just want you to come and lay down with them, or it's hard to separate them from their devices. So that's sort of the behavioral category. And then the final category really has to do with things that are present in that 24-hour period, but kind of has its own manifestations at night, right? So I would say in that category, things like, you have a child that has autism, or you have a child that has ADHD, or you have a child that's really anxious or has depression or other mood disorders or mental health issues. It's present all the time, but it does have its own presentation at nighttime. So when we have these 3 broad categories, then it helps you then go down to say, how do we then intervene? Unfortunately, or in some situations, you have a combination of all 3, but I think it's still helpful to have those 3 categories, because then what do I need to work on first before we go on to the other.
It's really helpful to break it down that way, because sometimes with sleep, it can feel really overwhelming. Like, oh my gosh, I'm not sleeping, or my kid's not sleeping. Let me just give them some melatonin and see if that helps. But actually, to have this kind of systematic framework to understand what's going on is really important, right? Because we need to address the root causes. And I say this to my adult patients all the time. We need to figure out why you're not sleeping. And there's lots of reasons for that. So for physicians who are listening, or therapists, or parents of kids who are struggling with sleep, when should they go and see a sleep specialist like yourself?
Yeah, absolutely. So, and I just love to start let's even start from the basics, right? We call it sleep hygiene. I'm not a fan of sleep hygiene. I call it healthy sleep habits because I don't know why the hygiene piece comes in. What does sleep have to do with cleanliness? I don't know, but anyway, it's a thing. But just first starting off to make sure you have a good sleep foundation. So what does that look like? You're already maintaining as much as possible as a parent. You're already recommending consistency in their sleep time, their wake time. You already have a routine in place that they're following. You've already done things like making sure the environment is supportive of good sleep. So it's not noisy, it's nice and dark. The temperature of your bedroom is lower. You've already dealt with technology issues where you have a limit to when you're, exposing them to technology before bedtime. You're already making sure they're not drinking caffeine or substances that could potentially be keeping them awake. So as a parent, you've done all that. As a physician or, a special or, care provider, you've already recommended that and they're still having issues. That may be a time to say, you know what, let's delve deeper into this. And alternatively, also, if you notice that they're having snoring, and this is not just like snoring, when they have a cold or snoring during allergy season, because those can cause intermittent snoring. But this is they're having habitual snoring, and it's causing daytime effects, or they're just having constant snoring, or they're waking up unrefreshed. That's a reason when you should potentially be referring, because they may have sleep apnea. Or if you have a child who is extremely restless at nighttime, and while some people tend to move around a lot at bedtime, it may not be a problem. But if you have a child who is really restless at nighttime and it also has difficulties waking up in the morning, or has, daytime behavioral issues, they're hyperactive, they have focus difficulties, they're excessively sleepy, things like that. For me, that may show that something's up with the quality of their sleep. And so something may be disrupting their sleep. Again, it could be sleep apnea. It could be what we call periodic limb movement disorder or restless leg syndrome. And so those things should be cues to the fact that, okay, something else is going on. And then a final one would be, usually, again, I would say like up to 70% of children with ADHD have sleep problems. So that's a lot. And while as a pediatrician in your very busy practice, it might be very hard to delve into how to address that. So if you do realize like, okay, we're doing all the basic things, this child is still having troubles with their sleep, then that may be another population you want to refer to a sleep specialist.
Yeah, that's really important. With kids, and this is something I remember from working in the pediatric sleep clinic during my training, which is that
Mm.
kids often present with irritability and hyperactivity during the day, whereas adults with sleep issues usually present with fatigue and sleepiness and problems with concentration and things like that. But for kids, it's
Mm.
more this hyperactive ADHD like
Mhm.
constellation of symptoms. So I think
Mhm.
that's really important because I'll see a lot of kids being put on Ritalin or stimulants for ADHD management when it actually could be untreated sleep apnea or restless leg or some other sleep disorder.
Yep, exactly. Absolutely.
So for doctors who are, seeing these kids, what are some initial strategies they can start with as part of their assessment or any recommendations, whether it's behavioral or blood work they can start with? Should they go ahead and do a sleep study? Should they refer out? What are some things that doctors can be doing?
Absolutely. So I think it all depends on what you're going to do is going to be dependent on that history. A very good history is such a big piece of it. And I would use this opportunity to tell you that not every child needs a sleep study. And so many times, kids get referred for a sleep study, and the problem is they can't sleep. If they can't sleep, then a sleep study is not indicated because all we're going to do is bring them to the sleep lab and just watch them awake. And that will just confirm the parents' complaint, which is, yeah, they don't sleep, right? So the history is going to be very important. If your child is having a very long sleep onset, for instance, then they may, and they don't have any physical symptoms, then it may potentially be a behavioral issue. It may be, related to anxiety, in which case really approaching it from one on this underlying, treating whatever that underlying anxiety may be. If it's a behavioral issue, there are different strategies we look into, because with kids who have sort of what we call behavioral sleep issues, it may be that they are codependent on a parent to fall asleep. So in that case, we then will just work on helping them to achieve sleep independence, helping that parent to leave the room while the child is still awake. And this is a whole graduated process we use. I mean, there's so many other alternatives to that. If the child, say, for instance, has, yes, maybe discomfort that they're complaining of in their legs or in their extremities, then in that case, it might be worth checking a ferritin level. And the reason why is because we know that restless leg syndrome or periodic limb movement disorder is associated with low ferritin stores. And so sometimes just giving them iron supplementation for about 3 months tends to do the trick. If they have what seems like frequent nighttime awakenings that you don't feel is related to, oh, they're waking up again and realizing that a parent is there, can you come back to bed with me? Like, it's not a behavioral issue, then that may be an indication to say, okay, let's see what a sleep study will show. Is there sleep apnea? Is there, periodic limb movement and things like that? So those are things that would kind of help guide you. If they have, daytime concerns, right, that you feel may be contributing, like I mentioned, you have a child who, for instance, is maybe needing, like a teenager, for instance, who's constantly needing caffeine, constantly falling asleep on the school bus, constantly falling asleep in class, and seems to be getting sufficient amount of sleep, for instance, right? For our teens, we may not necessarily be aware of if they're snoring or not, what's going on. In that kind of situation, you may want to get a sleep study. Narcolepsy is something that happens in that age group. So depending on other symptoms they may be having, you may want to consider a multiple sleep latency test, in which case, of course, by then you would be referring to a sleep specialist. So for you as either a generalist or a pediatrician, I think those behavioral pieces are really important to try to address, and then really knowing when to say, okay, you know what, I think this child does have sleep apnea and may need a sleep study. Then, your history and things like, and your physical examination, big tonsils, for instance, will guide you.
Great. That's really helpful. And I think those are some really simple, actionable tips that people can use in their practices with their patients. I'll add one more thing that I like to use in sort of the adolescent and young adult population, because I do see people in their like early 20s and things, and delayed sleep phase syndrome is pretty common in that age group. And I like to also just give them a sleep diary, like if they're old enough to fill it out themselves. And I just use the free one, the American Academy of Sleep Medicine, free downloadable PDF sleep diary, and it gives you a nice picture of what's going on.
Yeah. Thanks for mentioning that. That's really important. That's really helpful too, because sometimes when we're reporting symptoms that our kids have, and it's at the moment, it seems awful, especially, or at times they have seasons. They have times when their sleep is better, when it's worse. At times they have changes in patterns. Like on the weekends, you may notice that they're sleeping in excessively. And so a sleep diary is so informative. Usually I would say you fill it out for about 2 weeks before you come to see me, because then that gives me an idea. By then I already have like 2 weekends. So I know what's going on with sleep on the weekdays. I already know what's going on with sleep on the weekends as well. And with delayed sleep-wake phase syndrome, there's just a shift, right? Most teens around puberty have just a normal physiologic shift in their circadian rhythm, so they don't naturally go to bed at your typical expected time. So your 8-year-old that could be going to bed at like 9 or 8:30 or 8 p.m., by the time they become teenagers at 10 p.m., they're just like, no, I'm not sleepy, right? And that's sort of a more natural shift that we see. But in delayed sleep phase syndrome, it's almost like a super exaggerated response to that, where their bodies just have this shift up to an extra 2 hours from when their typical bedtime will be. And then the problem is that they do want to sleep in so that they get enough sleep. Unfortunately, because of the school systems, they have to wake up early. And so they're really short on sleep. And then on the weekends, they try to catch up. So you can see there's just so much change and variability, such that I think a sleep diary would be very helpful in helping with figuring that out. And then another one I just wanted to put in there in terms of what to do, because I do get a lot of questions about melatonin. And recently there's been an incredible uptake in the use of melatonin for sleeping kids. And, there's so many preparations available now. We have the chewable, we have the gummy, we have the liquid, the suspension. You have all kinds of forms. And I think while maybe on the short term, in some situations, it would be recommended, for example, in children, again, with neurodevelopmental differences in autism and ADHD and things like that, that's recommended. In children in adolescents with ADHD, there's a little bit of research to show that it is helpful. And with delayed sleep-wake phase syndrome, there's a little bit of evidence that it is helpful in sort of bringing a phase shift where it kind of brings their circadian rhythm forward so they could fall asleep a little bit sooner, as well as in jet lag, more in adults, but we sort of extrapolate that in adolescents. You can use it. Honestly, outside of that, the use in typically developing children for maybe behavioral insomnia, it's not really that robust. People are desperate and want to try anything. And some people feel that it helps. In some situations, it's more of a placebo effect where they feel like they're at least doing something. So that's one area that I would say you do have to sort of exercise caution in terms of recommending it routinely for parents to give their kids.
And I know there's some people often have questions about the hormonal effects of melatonin, because melatonin is a hormone.
Yeah.
And what is the research showing about effects on children's development, hormonal development, when they're taking melatonin on a consistent basis?
Yeah, exactly. So again, the studies are not it's not been consistent. The findings have not been consistent. There have been some studies that have shown that it does cause some changes in puberty, especially when you're using it over a long period of time and you are using sort of more of the higher doses, because the amount of melatonin our brain produces is actually extremely small. And so when people are given this medications or hormones, right? It's not necessarily a medication. We're giving it in supraphysiologic doses. So this, again, some of the most studied population is being in children who have autism, ADHD, some other like Angelman syndrome, some of these other syndromes. And what some researchers have postulated is that those children tend to have some abnormal production of their melatonin. Now, whether it's in lower doses or whether it's shifted, it's not completely clear. But then they've done studies in those kids for, I don't know, upwards of like 2 years or more, and they found them to be relatively safe. They did find side effects like, of course, excessive daytime sleepiness. They found some children had increase in nightmares. Some children had increased bedwetting. In terms of the pubertal changes, again, it wasn't consistent across board for those studies. But I think just knowing that it is a hormone makes us say it's the fact that it's it's not FDA regulated in the US, and so it's available over the counter. So people just assume it's 100% safe, but there can be some side effects. So I would just be cautious.
Well, Dr. Funke, that was so helpful, and thank you for sharing all of this knowledge. And I think we'll have to do another video on pediatric sleep, because I get so many questions about it. And like I said, I'm not a pediatric sleep specialist, so I think there's a lot more we could go into here. But if people want to work with you, how can they find out more about you?
Yeah, no, thank you so much. This has been fun. Well, the best place to find me is on social media. I'm at Restful Sleep MD. And then I have a website, it's Restful Sleep MD, one word, restfulsleepmd.com. I offer one-on-one coaching programs for moms. And so that's definitely somewhere where we delve into a lot of issues with mom sleep, around limiting beliefs around their sleep, around issues around their kids' sleep, so that as a mom, you can be empowered to coach your child to sleep well. And when you do that, you get to sleep better. So you can schedule a call with me through my website. I am accepting clients currently.
Great. And we'll put all of those links in the video description. And again, sign up for our Women's Sleep Summit. We'll be going through various aspects of optimizing sleep for women. There's 8 of us, international sleep experts, sharing our favorite tips and insights. So you can sign up at womensleepsummit.com, and it's taking place March 4th and 5th. So thanks again, Dr. Funke.
Thank you. Good to see you.
Anyone watching, if you're new to this channel is all about sleep education for physicians and therapists. As physicians, we only get about 2 hours of sleep medicine training during medical school, but all of our patients have to sleep. So subscribe to this channel if you want to learn more about how to support your patients with the power of restorative sleep.